Today, I'm really pleased to have with me Dr. Ferhat Uddin from the Liberty Health Clinic. Hi, Ferhat.
Hi, Joe. Lovely to be here.
Can you tell us a little bit about what you do?
I'm a menopause specialist. I trained as a GP, developed an interest in women's health and then menopause. So I've done my advanced training in menopause care to become a menopause specialist. So I still do work in the NHS, but I run a private clinic as well called Liberty Health Clinics, which is an online menopause clinic.
When you were working in the NHS, did you find that GPs were educated about menopause? And
I think it has been historically quite difficult because I think the training that was available to GPs hasn't focused enough on the menopause, and things are slowly starting to change. But actually, one of the reasons I ended up doing my advanced training in menopause was because I really did feel like we were failing women within the NHS. I personally saw lots of women coming to me who had been refused HRT or had literally just been told that they were just imagining it wasn't the menopause. And then even the ones who were started on HRT, I found that there were so many who either didn't get on with it, weren't given the right type, or GPs didn't know how to manage the side effects. That was really what spurred me on to do my advanced training so I could reach more women in those situations. It's still a passion of mine, and definitely the education side of things, which is educating GPs and also raising awareness of the menopause, is something that I'm doing continually and really passionate about.
I think we're becoming educated ourselves now so much more about HRT, aren't we? Which is so much better if you can take control yourself of your health and understand your body. But one of the things I found very frustrating when I was going through it, which I have to say is some time ago now, before we were all talking about it, is that I would go in with one symptom, such as palpitations, and they would send me to the heart clinic. And then I'd go in with aching joints and they sent me to the knee guy, and
the orthopedics,
Yeah, it's an allopathic system, isn't it? Nobody ever sort of put two and two together and thought, hang on,
join the dots.
Broken shoulder. She's got problems with her knees. She's got palpitations. She's suffering from anxiety and depression. Could it be something to do with hormones? Nobody ever suggested it.
No, absolutely. And that's the thing. And I think it's almost that the system's slightly broken as well, because you have 10 minutes with your GP and often they will, they don't have the time to delve into, well, what else is going on? So some of the responsibility lies on us as the patient now to make sure we're clued up, we're able to give our GPs the correct symptoms so they can join those dots really quickly. And in some situations, you almost have to go in and say, right, I'm going through the menopause. This is what I would like. So absolutely, there's still work to be done. And one of the things that I do is educate GPs that if you see a woman over the age of 45, if they've got X, Y, and Z, think menopause. Definitely, if they've got low mood, if they've got anxiety, don't think depression. If they're over the age of 45 and it's a new symptom, think menopause. So I think education is so key. And we are slowly getting things changing, and hopefully access for women is better when it comes to HRT, but there's still a way to go.
Yes, there is a way to go. But I think that with this generation of women coming through that are now hitting menopause, the generation below me have been very much more go-getting than, generally than my generation, and have been more forthright in asking for what they want. And I think that's
absolutely,
and that helps the whole thing sort of start to change.
Definitely. And I think one of the things as a GP is really managing risk, because there is still a fear with prescribing, and there's a fear that you don't want to do the wrong thing. But if a woman comes in and says, I've done my reading, I know what the risks are and I know what the benefits are, and actually I'm happy with those small risks, it takes a weight off your GP's plate, because they're like, right, well, actually she's happy to go on this, she knows what she's doing to an extent, and they only have to fill in a few of the other gaps. I think the fact that as a generation now we are more empowered has made things easier on medical professionals.
It's become more a partnership.
Absolutely.
If I think of the generation above me, I mean, we were still being treated for hysteria. It wasn't, oh God, how old am I? But a woman going through her, she would never go and question her doctor or go in and say, I think I've got this. Talking about if you've done your reading, can you recommend where to do the reading? Because Google is a huge place, and Dr. Google doesn't always get it right.
I'm a member of the British Menopause Society, and I think when it comes to information and doing things the right way, that's where our guidance comes from. And the patient arm is called the Women's Health Concern. So if you look up the Women's Health Concern, they have lots and lots of leaflets and fact sheets and information, and it's evidence-based. So when you're looking at the risks and the benefits, everything that's on there is on the back of trials that they've done and studies that they've looked at. In terms of the most evidence-based, I would go on the Women's Health Concern to find the information.
Right, that's excellent. Thank you. I will put that in the podcast notes. So just briefly, just tell us what happens to a woman's hormones when they sort of hit their 40s.
Sure. So women are born with a finite number of eggs within our ovaries. And as we get to perimenopause and as we get to midlife, these eggs start to run low. And we're still having periods, but our periods start to get irregular as some cycles we ovulate, some we don't. And it's that irregularity of ovulation that leads to our hormones having huge swings. So the main hormone that really causes the symptoms is the estrogen. And what we see is that the estrogen goes up and down in perimenopause. And sometimes when your estrogen's in your boots, when you have one of these big swings, that's when you'll get mood swings, anxiety, joint pains, maybe sleep disturbances. And then as your estrogen goes back up again, some of these symptoms resolve. So women say, well, actually, I'm feeling okay now, but the next cycle will come and again, they'll get more symptoms. So it's that up and down of hormones in the perimenopause. And then when your periods stop, that's what we classify as menopause. And again, at that point, your estrogen is much, much lower. And that will trigger some of the same symptoms, some new symptoms. You might start experiencing bladder issues. You might start experiencing more vaginal dryness, for example, or more mood changes. And the risks change. We know that our bodies need estrogen for all sorts of things. In fact, we have estrogen receptors all over our body, our brain, for example, which is why we get the brain fog and the poor concentration. But our hearts, our bones, we know that after menopause, the lack of estrogen puts women at a higher risk of osteoporosis and fractures. Women are at a slightly higher risk of heart disease because our estrogen keeps the blood vessels in our hearts nice and elastic. So things do change at midlife and at menopause, and the estrogen, well, it just has such a huge number of effects on our body.
I mean, everything's so erratic, isn't it? It's not like it's a line of decline in estrogen.
No.
So I remember sort of maybe missing a period, but then, flooding or having a very light period or only lasting a couple of days. And then I'd have a 3-week cycle and then I'd have a 6-week cycle. And you just never knew whether you're coming or going, do you?
Absolutely. So your hormones are all over the place and not had a period for a while. And when you do ovulate, you often will have a much heavier period or a much longer period.
Mm.
So it's, it can stay erratic for a number of years. The average number of years is 7 years, those swings, the perimenopause, but for some women it's 10, it's 15 years. So it can be a really long time for some women.
It certainly feels like a long time when you're going through it, doesn't it? You forget what it was like to have that regularity.
Not sought help as well. I think it does drag on.
We talked about estrogen. What progesterone, the other sort of the twin hormone, as it were, what happens to that as we go through it?
So progesterone declines as well, but not quite at the same rate as estrogen. And actually, we don't need progesterone in the same way that we need our estrogen. So some women, in fact, when we put them on HRT, we will just replace the estrogen. For example, women who have had a hysterectomy, or maybe they've got myrinecoilin. If we don't need to protect their womb, we don't need to give them progesterone.
But if you still have a womb, it's important to take progesterone at the same time.
Absolutely. So progesterone, the main reason we give it is it almost works like a lawnmower. When we give estrogen, imagine we're almost watering the lawn, which is the lining of your womb. Then we need to trim that lining. We need the lawnmower to come in and make sure your womb lining stays nice and thin. And that's the job of progesterone. And if we don't give progesterone, or we're not giving it in the right way, we do sometimes see the lining of the womb thicken up, and that puts women at risk of endometrial cancer.
Yeah. But again, it's worth doing the reading so you can see what the risks are and weigh that up, the risk versus benefit. I know I made that calculation myself because I had a slightly thickened womb lining, and looking at the statistics on whether I might get womb cancer and what would happen if I did get womb cancer and so on, I took the decision that the benefits were far outweighing for me. Those minor risks. So as long as you keep it.
And women who are on combined HRT, which is HRT that you take both the estrogen and progesterone every day, have a lower risk of endometrial cancer than women who aren't on combined HRT. So actually, long term, you are probably reducing your risk by going on combined HRT.
Yeah, I see. And what's less known about is also our testosterone drops, doesn't it? Because women do have testosterone.
Absolutely. So that's another one of our sex hormones. And, and I think sometimes it can be the missing link. In a lot of women, one of the things we see is we replace the estrogen, some of the symptoms improve, but some of them don't. And libido is a big one that women complain of, that, we do feel better, but we've just completely lost our libido. And testosterone can make a huge impact there. So yeah, also for some women, energy, brain fog, it can give you that get up and go that some women have just lost. I mean, I think the problem is the evidence isn't there for the other uses. The evidence is there for loss of libido. So we can prescribe it for women who have lost, their desire or lost their libido. We find that it helps in other areas too.
So do we have a formulation that's designed especially for women? Because I think a lot of women would be worried about, suddenly developing a moustache or nose hair.
So we do, but we don't have it on our NHS formula at the moment. So there is a form called Androfem, which is imported from Australia, I believe, but we can't prescribe it on NHS, unfortunately. But we do have the male forms, and they are, they're regulated, and we are allowed to prescribe those for women. And the way we mitigate against side effects is we do blood tests. We make sure the testosterone is within the normal physiologic range for a woman. And doing that, we prevent any of those side effects. The facial hair, the voice deepening, loss of hair is another potential side effect. But personally, I've never seen them because we keep a really close eye on the blood test to make sure that you're not taking too much.
Yeah. I think that this is something that I personally find reassuring, is I like to see the chemistry in conjunction with my doctor, which for HRT is you, of course. It's all right looking at symptoms and so on and doing that puzzle, but I actually like to see the numbers. But
absolutely,
that's just me. Maybe.
Well, no, they say, I mean, we don't need blood tests to diagnose menopause. That's key. And sometimes I see women who are fobbed off because their GPs have done blood tests and they're normal. And they often will be in the perimenopause because, like I said, you get those swings in estrogen. And sometimes if you take a blood test on a day where your estrogen's in the normal range, it will come back as normal. But I do sometimes do a blood test after starting women on HRT. One, to make sure that we are replacing adequately, especially women who are at risk of osteoporosis, bone thinning, maybe they've got a strong family history of fractures and osteoporosis. I will do a blood test to make sure that we're giving them enough estrogen to protect their bones, and measure testosterone, because if your testosterone is in the boots, that could be the reason you're not feeling great. But that initial blood test is really necessary if you're worried about other causes and you want to rule out other things. No, but I agree. It's quite nice to have a number, isn't it?
Yes, and to see an improvement
know what's going
as well.
on.
Yeah,
absolutely. Yeah.
Do you feel that supplements and so on and less medicalized ways of managing HRT, can they be effective for most women?
I think there's a range. And again, we've got a range of symptoms, and that's why we've got a range of treatments for those symptoms. And yes, absolutely. I've seen women who have just changed their lifestyle. They've started eating more healthy. Maybe they've switched to like a plant-based diet, introduced more exercise, reduced the stress in their lifestyle, and their symptoms get much, much better and manageable. But there are others whose symptoms are more extreme or not manageable, or who've tried other things, and maybe they've tried supplements you can buy over the counter. There's actually quite a few on the market. You've got things like red clover, and you've got a few other ones on the market as well. And I think it's varied. The response is really varied, and generally, if you've got milder symptoms, they seem to work a bit better. And as your symptoms, possibly get worse, HRT tends to be the more effective way of controlling symptoms. Not in all women, but definitely a lot of women find that when other things haven't worked, HRT does work.
I know a lot of women worry about the medicalization of menopause and perimenopause and medicalization of women's issues in general. But if you're actually missing something, I guess all we're doing is replacing something that keeps us healthy and strong.
Absolutely.
I mean, years ago, we didn't live past 50, did we? And
well, this is it. Times have changed, and I think the responsibility that we're under, and absolutely we are living longer. And to spend, almost 50% of your life without your estrogen can be detrimental. And for me, I think actually when you look at how far we've come in what we prescribe, it is so much safer than it used to be, say even 20 years ago, that when the risks are so much lower and the benefits are so much bigger for most women, it makes sense to improve our quality of life.
Absolutely. And that's what we deserve, isn't it? A good quality of life. And so many are working sort of into our 70s as well. We need a little bit of help with that. So we've talked about the safety of it and whether it's the answer for women who haven't had a good effect with red clover and etc., or who want something extra. There are so many myths around it. Does it delay the menopause? So if you take HRT, so if I suddenly stopped, would I suddenly go back into those symptoms?
No. So that point at which your symptoms go is going to be the same whether you take HRT or you don't take HRT. So if you come off HRT and those symptoms are still there, well, you haven't been on it long enough. And often if you go back on it and maybe try another year later or 2 years later, your symptoms would have resolved. So it's not delaying it. It's really just, we don't know when those symptoms would stop. So it's really hard to say, you need to be on this for 5 years or you need to be on this for 10 years. So no, it doesn't push it back.
Right, thank you. I mean, that's something that people often say to me, well, you're only going to have to go through it again later, just putting off the inevitable. Women tell me that their doctor tells me that once they hit 60, they need to stop.
So again, that's a myth. Got lots of women who I treat who are still on it in their 90s, would you believe? It's a very individual decision whether you carry on or you stop it. And we want to do an assessment once a year where we look at what's changed. Are the benefits still outweighing those risks? And if they are, we're happy for you, if you want to carry on with it, to continue taking it, because those benefits are there. We know that there was a study in 2012 where they looked at healthy women who started combined HRT straight after their menopause, took it for 10 years, and the study showed that they had reduced mortality and a reduced number of cardiovascular events, so less heart disease, less stroke, which is huge. As you come off the HRT, actually, in healthy women, you are increasing your risk again. And then there's the benefits for your bone, but you do have to weigh it up against that small risk of breast cancer. And we know that it is small, but actually what the studies show is that there's no increased risk of mortality, but there's a small increased risk of the incidence of breast cancer. So it will vary. If you have that assessment once a year with your doctor, they will talk about what your other risks are, whether there's a family history of breast cancer, whether there's a family history of blood clots. And it's a decision you need to make with your healthcare professional once a year. But many women will happily carry it on.
So we've talked about how to approach your NHS doctor. That will be by doing your research first.
I think you need to have a list of your symptoms.
Yes.
And I think it really does make a difference because it makes life a lot easier for GPs to put that puzzle together.
Do you think most GPs nowadays are open to it being a partnership?
I wouldn't say all GPs. We've definitely seen the tide turning, and I think there is less resistance and there's more onus on the patient now, especially when, I think the fact that continuity of care isn't always there. You're not always seeing the same GP. You have to take control of your health. You have to know what's going on with you so you can relate symptoms and signs and diagnoses to the next doctor. So I think there's definitely an understanding that patients will be taking more ownership of their health, and that's perfectly fine.
To me, it can only be a good thing, to be informed about your health and then take the advice of a health professional. It's not a case of saying I know best and I'm not going to listen to you, is it? It's working together for the best.
Absolutely. And it will often be a compromise, and I think one of the biggest areas that sometimes we struggle with is women who have had breast cancer, and some women struggle so much that they will still want the HRT, and that's fine. We will come to a compromise. Maybe I would have prescribed a few other things first that they've tried. That's the compromise we reach. And if at the end of the day they still want it and they understand what the risks are, then that's up to them. But it's definitely a partnership between us.
Yeah. With Liberty Health Clinic, what can you offer women that they're not going to get in their 10-minute GP appointment?
Exactly that, really. One of the reasons I became a bit disillusioned with the NHS was because of the lack of time, the lack of, being able to really delve under the surface. Because treating menopause isn't just, right, here's a prescription for HRT, there is so much more to it. You have to really, to optimize how you feel, you do need to tackle it in a holistic way. And what we do is yes, of course, we do look at HRT, but we also look at stress, and we look at your diet, and we look at other ways that we can optimize your lifestyle. And we do a really deep dive into your family history, what you're worried about, what your risk factors are. So you really know what you're getting yourself into. And I think that's important. I think you have to be happy with what you're on, what you're taking, your decisions. And then obviously not everyone gets on with it. If they do decide to start HRT, you don't always get on with the first thing that you're prescribed. So what we do is we tweak it, we try different things. We know how to adjust the medication. And then there is the testosterone, which I think in the NHS, it's a struggle to get. Most GPs won't prescribe testosterone. So as a menopause specialist, that's an area that I'm privileged to be able to prescribe. And I can see how much it helps women who need it. So there is that extra step.
Yeah, but it's the whole thing about being heard, isn't it? And being able to discuss your concerns in detail with somebody who really does understand that side of medicine and also that side of women's life. So we'll put in the podcast notes how people can get in touch with you. I mean, you can still go back to your GP and be prescribed through your GP. The consultations where it's really useful to be able to speak to a menopause specialist. Thank you so much for taking the time to explain all of this to us and to tell us about what you do. And
thanks for having me on. It's been great.
You've been listening to the Midlife and Beyond podcast with Jo Blackwell, where we're changing the narrative on aging, one story at a time.